Good afternoon and welcome. We're glad you have tuned in today to learn about how you can improve your vision by considering laser vision correction surgery. Before we begin, I have a couple housekeeping items. We invite you to use the Submit a Question box to ask our presenter a question anytime during the webinar. Check our website, www.medicine.uiowa.edu/community for upcoming educational programs across the state of Iowa for children and adults. Next, let's introduce our presenter. Dr. Ken Goins is a clinical professor of ophthalmology and visual sciences. Now, let's begin our presentation.
I'm Dr. Kenneth Goins, and joining me is Ms. Lisa Milder, my refractive coordinator. We're going to talk about laser vision correction and what we offer at UIHC. If there's one take-home point that I want everyone to remember is that the cornea is the most important structure in the body. And so on this slide, you're seeing that the cornea is the window inside the eye for the ophthalmologist, and it's the window to the outside world for everyone. And so the cornea represents 2/3 of the refractive power of the eye, and we can reshape the cornea to improve your vision. Also shown on this slide is a crystalline lens, which represents another 1/3 of the power of the eye, and of course the iris, the colored part of the eye, which regulates the amount of light that enters the eye. We have about 3 to 4 billion people in this world, and 1/4 of these people are nearsighted. When one is nearsighted, when light rays enter the eye, they fall short of the retina, and it leaves us with poor vision. We can put contact lenses and glasses on the eye to bring these light rays back to the retina and improve vision. So the world for someone who's nearsighted is like this. This beautiful girl, you can see that she's clearly in focus, but notice off an infinity past her, everything is blurred. This is the life for someone who's nearsighted. On the other hand, 1/3 of our population is also farsighted. What does that mean? Usually when one is farsighted, light rays pass through the eye and they focus behind the retina, shown in this diagram. Again, we can use contact lenses, we can use spectacles to put these images back onto the retina. And if you're young enough, you might have enough inherent power with your own crystalline lens to put those rays on the retina. For most hyperopes or farsighted patients, this beautiful girl is not in focus up close, but notice off at infinity, everything is very clear. And so certainly if you're over 40, this is a familiar situation for you. Astigmatism, on the other hand, you have maybe 2 focal points of light, which they could fall either in front or in back of the retina. And so in this case, you've got 2 planes of light which enter the eye and they fall short of the retina. So this would be compound myopic astigmatism. You could have 2 planes of light which fall behind the retina. It'd be compound hyperopic astigmatism. And you can have 2 planes of light, one in front and one behind the retina, and it's just mixed astigmatism. Everyone has some form of astigmatism. Good thing about it is we can correct it. So what is the ideal refractive procedure? First of all, it's got to work. It needs to be safe. We all have families we have to take care of. It needs to be predictable. It has to have long-term stability, and then of course, since you're spending a lot of money, you have to have satisfied patients. And so the gold standard is the picture on the right, the contact lens. Everyone, all of you out there can put a contact lens on and correct your refractive error, and you'll see 20/15, but you might not be able to wear that contact lens for a long period of time. And so this is where laser vision correction comes in. The father of laser vision correction is Dr. Jose Barraquer from Bogota, Colombia. Probably back in the late 40s, he was seen as this strange man who would go into the operating room and he would dissect lenticules of cornea. Then he would run, while the patient's under general anesthesia, over to his laboratory, and he would freeze these corneal pieces with the cryolave and reshape them. And then he'd go back to his operating room where the patient was still asleep, and he would stitch them on. And so what was born was something called keratoconus. He had very good successes, but he had many failures. But he knew that he was on the right way. There needed to be some way to provide consistency to the procedure. Excimer Laser is what provided that predictability. It's not a new technology. It was designed in the 1970s. It's a cool laser which doesn't cause adjacent tissue damage. This slide, the picture that you see on the slide is a human hair where the excimer laser has been used to make columns within the hair. Notice adjacent to where the laser's been fired, there's no tissue destruction. So we can get into the cornea, reshape it, and not damage adjacent tissues. And so this is how we're able to do keratomileusis in a more predictable fashion. So what are your options today? There are two main procedures that we concentrate on. First one is photorefractive keratectomy, has an acronym PRK. So you hear that. PRK is basically we take the laser and we fire right onto the surface of the cornea to reshape it. Dr. Stephen Troquel in New York first did this in 1983 in a rabbit model. Dr. Marguerite McDonald, 1987 in New Orleans, did the first human patients. And so we have 30 years of information from Dr. McDonald, and she tells me that, yes, there is great stability with this procedure. In contrast, laser in situ keratomileusis, or LASIK. Again, as I mentioned, Barrick Hair was the father of keratomileusis. Later, Payman began to use the excimer laser underneath a flap in a rabbit model in 1983, again in New Orleans. And then later, Lucio Barato made the dream come true in 1989. He did the first LASIK procedure in Italy. And so in LASIK, what's done is we create a flap about 160 microns deep into the cornea. This flap is lifted, as shown, and then lasers applied to the center of the cornea. It's reshaped, and this flap goes back in position. So again, these are the most advanced techniques that we use to correct vision today. So what happens now? So we described what led up to what we do now, but what's going on now? Well, we can design a treatment specific for you. So not only can we correct what's in your glasses, we can correct other aberrations within the eye. And that's what's called a custom view treatment, or a wavefront guided treatment. We use the same treatment algorithms as used by NASA, the United States Navy, and the United States Air Force. So therefore, it has to be a very good system. We're sending many of our military out into combat following these procedures because it provides very good vision. So when you come and see us, what we'll do is we'll take wave scan measurements on your eye, and then we will design a treatment specific for you, and then we'll perform that treatment. So here are questions that you should be asking yourself right now while we're talking about this. Am I a candidate? What are the risks? Is laser vision correction perfect? Do we stand behind our results? How much does it cost? What can I expect after the procedure? Are there any treatment alternatives? So hopefully we'll address those and some more. Am I a candidate? At 21 years of age, usually there's no more growth in the eye, and most people's spectacle and contact lens prescription, it doesn't change very much until you start hitting maybe age 40, when you start losing your ability to focus up close. So 21 years of age usually, although I've done patients as young as 1 year of age to help prevent something called amblyopia. We want good eye health in general. We try to, when we see you for a pre-operative evaluation, we're going to check for things like glaucoma, high pressure in the eye, and diseases like keratoconus, which is shown in the slide there, which the cornea has weakened collagen and begins to bulge, and this person's at risk from needing a cornea transplant if we perform laser vision correction. Patients who have macular degeneration tend not to like laser vision correction. And in herpes simplex keratitis, if you have a history of that, it can be exacerbated by laser vision correction. But we'll check you for all of these things. The ideal candidate should also have very good general health. Again, we'll ask you questions. Is there uncontrolled diabetes mellitus or hyperglycemia? Are there immunologic diseases which may affect wound healing, like systemic lupus erythematosus or rheumatoid arthritis? We'll ask also about migraine headache history, because sometimes the medications used to treat migraines can alter wound healing in the cornea. And then, of course, we like for our patients to have realistic expectations. Okay. I'll elaborate more. So who should avoid laser vision correction? I think that if you've never tried contact lenses, you should try contact lenses. Contact lens technology today is awesome. I hate to say it, I lose a lot of business to our contact lens service, but they do an awesome job and they help many people. Second, I want patients not to have unrealistic expectations. Occasionally I'll have someone come in, I'm going to golf just like Zach Johnson. I'm going to be able to hit that ball down the fairway, and I have to stop them and say, can you hit that ball right now like Zach Johnson? No. I says, well, okay, I can maybe help you a little bit, but you're not going to be as good as Zach, okay? Zach is Zach. He's a different person. Okay, those who are pregnant and nursing, the cornea tends to thicken in those situations. The cornea becomes more dry, and therefore laser vision correction, the wound healing process is very much affected, and maybe we don't get the desired outcome. So I like for pregnancy and nursing to I like for women to be done with that at least 3 to 6 months before considering laser vision correction. Those with a history of autoimmune disease, as I mentioned before, they may have altered wound healing of collagen. They may be on medications which also interfere with wound healing. And again, I try to avoid those situations. And many times those patients have severe dry eye. Everyone after laser vision correction has dry eye. And so we'll stage where you are in the process. And we may not be able to do your surgery because of that. So very important to consider that. And then there's systemic medications which alter wound healing, as I've elaborated on. So the anti-migraine medications, Cimetropin, which alter myofibroblast tone in the cornea. There are antidepressants, which also do the same, and they create dry eye. Vitamin A derivatives also create dryness. And then corticosteroids alter wound healing. Okay, what are the risks? Common complications after laser vision correction: undercorrection or overcorrection. Not a big thing. We can do a procedure called an enhancement or touch-up to make things better. These touch-ups or enhancements are very good early on. I think many years later after the procedure, they tend to lose their effectiveness. It doesn't mean that I can't do them, but they're not quite as effective as if we can do touch-ups within the first year of surgery. Everyone has night glare following the procedure, but usually by 3 months, I don't hear complaints from patients. And the reason they have it early on is because the cornea imbibes fluid, and it takes about 3 months for the normal patient to get rid of all that fluid, and then the vision becomes crystal clear. I think the most common reason why people have night glare late would be uncorrected refractive error. And again, that's where the touch-up or enhancement procedure would be very important. Haze is very uncommon, but there's about 1 to 3% of patients that may develop haze following surface treatments, and that's usually associated with high ultraviolet light exposure. And so here in Iowa, we're safe. We don't have that high ultraviolet light exposure. And then, most importantly, what is your chance of becoming blind? Things that would take your vision following laser vision correction would be an infection. And the chance of getting infection is maybe 1 in 3,000 to 4,000 cases. But if we work together as a team, you follow instructions and I follow strict antiseptic protocols in surgery, I think that we're going to be fine and avoid infection. So your chance of being legally blind following laser vision correction, having a best corrected vision of 2200 or worse, is less than 0.03%. So it is very safe. Is laser vision correction perfect? Well, nothing's perfect, although I tell my wife she's perfect, so because I want to stay married. But laser vision correction is designed to restore vision to its normal, natural state. It's not going to eliminate your need for reading glasses once you reach 40 to 50 years of age. Okay. Do we stand behind our results? Yes, we do. We're trained to make a difference. And so I think, as I said before, if we work together as a team, patient and doctor, you keep your scheduled appointments and you use eye drops as instructed, we'll do our part by providing the best technology to improve your vision. Now, this is the generation of big data. Everyone's looking at outcomes, and so we're doing actually the same thing in our laser vision correction practice. And so we've compared our results to the VisX. The VisX is the laser platform that we use, and so the VisX FDA study was finally approved in 2003. What did it show? So for myopia from -1 to -6, 100% of people could pass a driving test without glasses and contacts. 98% of people could see 20/20 or better without glasses and contacts, and 70% of people saw better than 20/20. How are we stacking up? This is data. It deals with approximately 300 patients, 600 eyes, and it's our first 4 to 5 years using the same treatment platform that we use now. We had 97% of our patients seeing 20/20 at 1 year, and 76% of our patients seeing 20/15 at 1 year. We did pretty good. I want you to remember this number, 93%. I looked at all of our patients from 1998 to 2008, and so we treated patients from hyperopia as high as 5 diopters to myopia up to 14 diopters. And first go around, we had 93% of our patients 20/20 or better at 1 year. We did pretty good. We had a touch-up rate of about 5 to 7%, also the enhancement procedure. We looked at long-term stability in our wavefront guided patients. We've got 4-year follow-up. A lot of our patients are younger and they tend to leave, and we can't get long-term data, but again, we've got good long-term data on over 300 patients here, and what we're showing is that early on there's a little bit of a drift back towards myopia, and it remains stable over time. And so now that we know this, we can build a special nomogram for you. If you're a little bit older, maybe we'll leave things alone, because maybe drifting back towards myopia when you're over 40, not a bad thing, depending on what you do. But if you're 25 years old, you don't want this, so we know that we need to give you a little bit extra correction. So we're working to make things better for you. Where is the procedure done? Our laser refractive center is at Iowa River Landing. This is our beautiful building. We're on the 2nd floor. Please come and visit us. Right next to us is an optical shop as well. Now, very important, how much does laser vision correction cost? Unfortunately, most insurance plans don't cover this, so it's an out-of-pocket expense. But if you're a UIHC employee or a student, you get a 10% discount. So the cost for laser vision correction, PRK and LASIK, is $2,200 per eye. We do other things. We do something called INTACS, and I'll explain what that is in just a moment, and also collagen crosslinking if you have weakened cornea and we're trying to strengthen it. That's $2,500 per eye. And then there's some patients that just aren't good laser vision correction candidates, but maybe we can help them with intraocular surgery, and that's called a refractive implant surgery. And so it's twice as much. It's $5,000, but it's very effective. What's included in the fees? Your laser vision correction procedure, and then all the postoperative visits for 12 months. The 3-month visit is very important. We'll have a long conversation on how happy you are. If you're not happy and you need to see better and there's significant refractive error present, we'll talk about doing an enhancement procedure, a touch-up procedure. Okay, there's a small cost for that. Usually it's $250, and it's just for the treatment card so we can program the laser. What can you expect following the procedure? Well, with LASIK, we try to always do LASIK whenever we can because the recovery time is so fast. So you're back to work after 1 to 2 days of rest. Typically, the vision is very good the next day. There's great vision in 1 week, and there's mild discomfort for 4 to 6 hours following the procedure. PRK, on the other hand, you might need to take 3 to 4 days off because you'll need that day to recover. The pain response is more significant because there's an epithelial defect on the cornea. Good vision usually occurs at about 1 week and is typically great at 1 month. On the day of your procedure, plan on being with us maybe 2 to 3 hours, and all of that, we're going to repeat some of our parameters. We'll talk over the consent, and we'll go through the procedure. Then we perform the procedure, and then usually we'll take a look and make sure that everything is in good shape before you leave. Now, you've had your laser vision correction procedure. Everything is awesome. You're feeling like you're on top of the world, but that doesn't mean that you stop undergoing routine eye examinations. Older patients are going to be at risk for cataract, as shown on the left. And then on the right, I mean, patients with high degrees of nearsightedness, they're going to be at risk for retinal tears. And so good follow-up examination will be needed in many cases. Now, what are the alternatives? Let's say you've got a weakened cornea, or maybe your cornea is too thin. Can we do something to help? If you have low degrees of myopia, maybe there's signs that you might have a disease called keratoconus. We can use something called INTACS. These are plastic inserts. We insert 2/3 the depth of the cornea. It reinforces the cornea. It flattens the central cornea and gets rid of myopia. And it was FDA approved in 1999, but now we tend to use it more for these maybe atypical cases where we're suspecting there's keratoconus, or maybe there's frank keratoconus present. This week, collagen crosslinking for the treatment of keratoconus was FDA approved, and so we're one of the few places in Iowa who participated in the Vidro FDA phase 3 study, and so we'll begin treating patients who have keratoconus, or maybe those who have early keratoconus. Maybe we can stabilize them so that they never go on to need a cornea transplant, and so that's our goal. And so on the right, you're seeing someone with keratoconus, and our goal is to treat someone early before the cornea becomes misshapen, stabilize them, and that way they can avoid surgery in the future. If you have a cornea that perhaps is too thin and or a refractive error that's too high, we can actually place the power of correction in your eye. It's like putting a contact lens in the eye. And this is one technology called the VERISICE. It's an iris claw lens, which works very well. There's a second technology which fits behind the iris called the Visian ICL, and which intraocular contact lens, which fits right in front of the crystalline lens, but behind the iris, the colored part of the eye. And so both of these very effective for higher degrees of myopia, and maybe the patient's not a good candidate for laser vision correction. What we often do is we'll correct 90% of the refractive error with the lens, and then we'll do a touch-up on the cornea with the laser. And so these are some of my most happy patients. They're almost always 20/15 because we can fine-tune things very well with the Excimer laser. If you're older, perhaps, let's say, I'm not saying 60 is old, but when you start hitting 60, you start getting lens cataract formation. We can do alternative procedures such as maybe earlier cataract surgery and put in a bifocal implant. It's not for everybody, but it is an option and very effective in specific individuals. So now is the time to consider laser vision correction. Technology is better than ever. And so why should you choose the University of Iowa? Well, we have great tradition in eye care at University of Iowa. Our ophthalmology program is the eighth ranked ophthalmology program in the United States. Our refractive surgeons are considered among the best doctors by our peers. Our clinical experience places the University of Iowa at the forefront, and we tailor eye care to meet your specific need. You know, we're a full-service ophthalmology practice as well as taking care of cornea and external diseases. I want to thank you for your attention, and we'll open things up now and address any questions if you have any.
Okay, so we got some questions that came in. How does cataract removal affect or relate to corneal corrective surgery, either before or after cataract development or removal?
The biggest problem with cataract development is following laser vision correction. It's very difficult to measure the actual power of the cornea following laser vision correction in some cases, and therefore cataract surgery long-term outcomes or early outcomes are not as accurate. And so we have many different formulas that we use to help guide us, but there's always a chance that we might not get it perfect. And so I think the patient has to realize that going in. And so I think now with the advent of electronic medical record, a patient's preoperative corneal parameters will never be lost, and I think it will be very accurate in the future in taking care of patients who have cataract and need laser, who have had laser vision correction.
Is there a minimum thickness for a cornea to be eligible for laser vision correction surgery?
We try, if we do laser vision correction, specifically LASIK, we try to leave a residual cornea bed of 300 microns. And so, oh yes, there is a minimum, but it's patient dependent. And so in general, I try to leave at least 400 microns of residual cornea, whether we do photorefractive keratectomy or LASIK.
Is the cost on the slide, did that include the university employee discount?
No, it did not.
So it said, I think it said 2,200. It would be $1,980 per eye with the discount, $3,960 for both eyes.
That's correct.
Okay. Another question for you. Can you space out the surgery, one eye 1 year and then the other eye the next year to allow to take advantage of your HCSA for payment?
Yes, we will do that. In general, patients don't like having the eyes spaced too long. Back in the early days of refractive surgery, back when I was doing incisional keratotomy, like radial keratotomy, we would do one eye 1 week and then maybe the next week do the consecutive eye. And so I find that when I do both eyes together, patients are much more happy. They go through the procedure once, they have intraocular balance, and I think that if a patient has a large refractive error, I don't recommend this. But from a financial standpoint, can we do it? Yes. And hopefully that patient is a very good contact lens wearer so they don't have difficulty with what we call anisometropia. That's an imbalance between the refraction.
Okay, another question. If I have a history of migraine headaches, will I never be a candidate for LASIK?
Never say never. It depends on how severe the migraine headaches. I mean, if you require medications which alter serotonin tone in high doses, that doesn't mean that I can't do your surgery, but you can't pin me down for perfection either, because those medicines do alter wound healing, and so you're more likely to be undercorrected. And so I think if we go in thinking that, you know, we can certainly correct the bulk of your refractive error, and hopefully we have enough to do a touch-up. As long as we have an agreement that we might have to do, we're more likely to do an enhancement procedure, I think we can go ahead and proceed.
Okay, another question. How often have you done the alternative refractive solutions on high myopic patients with like a -16 with thin corneas?
These procedures, I did my very first one in 2008. I've done about 20 patients since that time, and I think the reason the numbers are low is just very expensive. I can tell you every one of them has done extremely well.
Okay. If someone's had glaucoma surgery in the past, is it possible that they can still be a candidate for laser vision correction surgery?
That's a very good question. When in glaucoma and laser vision correction, there are issues, and the issue is the following. When I remove 70 to maybe 100 microns of cornea to improve vision, I artificially lower the intraocular pressure of the eye, maybe 3 to 7 millimeters of mercury. If you have very significant glaucoma, we may not know exactly what your pressure is, and so it makes it difficult in management. So, but I think that we have very good technology today to follow optic nerve head nerve fiber layer thickness and ganglion cell layer thickness. So we have other technologies other than just pressure to follow patients. So I'm more likely to do someone who has controlled glaucoma today. If glaucoma is uncontrolled, I would say no. You go back to your glaucoma provider, get things stabilized, and then yes, we have a chance of doing the surgery. Well, thank you for your time. Hopefully this was informative. I look forward to seeing all of you.
Please keep your eye out for an email from us within the next 2 days, which is a program survey. You will also receive a follow-up email with information and links from today's presentations. Thank you again for attending the webinar, and we look forward to seeing you at future programs.